Welcome back to Medical Associates Health Check. My name is Dr. Laisha Selvaraja. I am the clinical administrator for Medical Associates as well as the head of accident and emergency. And my co-host with me today.
Hi, I'm Dr. Christopher Bristow. I am the founder of the Concierge Medical Clinic, and I'm a specialist physician in internal medicine.
Okay, so today we're going to talk about a myocardial infarction. Chris?
Big fancy words. Heart attack.
Right. And with us today, we have back again our favorite cardiologist, Dr. Ronan Ali.
Thank you. It's a pleasure to be back.
I'm glad to have you back. So let's start by what a heart attack is. Let's break that down.
Right. So a heart attack typically occurs when one of the heart arteries becomes totally blocked off.
Yeah.
So this usually occurs when a cholesterol plaque within one of the heart arteries basically cracks and a blood clot forms on top of that crack. And that blood clot can totally or partially obstruct the flow of blood, resulting in a heart attack.
Well, that doesn't sound good.
Like we say, serious like a heart attack, So like how serious is a heart attack?
Very serious. Heart attacks are life-threatening. Some people don't survive the heart attack. You often hear of patients who just sort of clutch their chest and drop dead. And that's what can happen.
Right.
Do you have any data to support what the death or mortality rate is like?
We don't have good data for the Caribbean in general. I mean, we have international data, but it's hard to extrapolate that to our particular unique milieu that we have here in the Caribbean. So we don't have that good data in terms of what is the mortality for heart attacks in Trinidad or the Caribbean in general.
But would you say that there is an increased risk within the Caribbean or within Trinidad and Tobago?
Oh, absolutely. Absolutely. We see a lot of heart attacks, and the risk is very high because our patient population, they don't like to come to doctors. They don't like to come to the emergency room. So that a lot of people stay home, as we say, kind of mining their chest pain. And that's probably the most dangerous thing that they can do.
Yeah, boy. Long time it used to be, you might see one heart attack in a week when you're working as a doctor.
No, not now.
No.
They're seeing 3 to 4 heart attacks a day. So there's a lot.
There is a lot.
So, Dr. Ali, we actually seeing younger and younger patients presenting to accident and emergencies or even to their private doctors with heart attacks. What's your take on that? You seeing that too?
Yes, we are seeing it. Heart attacks used to be thought of as a disease of older people. And we are seeing now 30-something-year-olds, 40-something-year-olds coming in with heart attacks. And a lot of the time what we're seeing is undiagnosed risk factors, severe uncontrolled risk factors, severe uncontrolled high cholesterol, severe uncontrolled hypertension, cigarette smoking, obesity, drugs of abuse, cocaine, etc. So all of these are risk factors, and we have to be vigilant in terms of the younger patients and think about heart attacks when we see them as well.
Yeah.
Let's talk about the signs and symptoms that people present with, because, there's a wide range actually.
Yes, most definitely. The most typical or classical symptom is chest pain.
Of course, yeah.
And some patients actually don't think of it as pain. It could be pain or heaviness or tightness or discomfort in the chest.
Say, doc, it's a pressure.
Pressure type pain. Sometimes it can travel or radiate up to the jaw. Sometimes it can travel or radiate down the arm. It's usually of a more prolonged duration, so usually 20 minutes or more. Can be associated with shortness of breath, can be associated with nausea or vomiting or cold sweating. All of these are warning symptoms or warning signs that you need to get checked urgently.
You're talking about the common symptoms there, but we have so many people that present, well, we use them atypical.
Right.
But, unusual symptoms. So can we go into that so people have an idea of what to look out for?
I mean, anybody can present with a heart attack without typical chest pains or heaviness or tightness, but there are 3 big patient populations that we think of as having atypical symptoms or less likely to present with the classical pain or heaviness or tightness in the chest. Diabetics, the elderly, and women.
Why women?
To be honest, we're not quite sure, but it has been well documented that these three patient populations tend to have less of the typical pain or heaviness or tightness. They may have some of the other symptoms, the cold sweating, the shortness of breath, the nausea, the vomiting. And what's also well documented is that these patients who present atypically get treated later
Right.
and therefore have worse outcomes.
Right.
Because when you present to the emergency department without the typical pain or heaviness or tightness in the chest, the doctors are less likely to think, oh, this person is having a heart attack, as opposed to someone who presents with typical symptoms and all of the protocols are immediately engaged and we get them in quickly, etc., etc.
You know, like a heart attack is like, to me, a heart attack is like end stage game, right? Because a heart attack will just happen, so not all the time. It's something that is building up underneath, you know, for a long period of time because of other reasons, other risk factors. What paint a picture of what that person might look like or might be doing that puts them at risk for having a heart attack?
Well, we have the classical risk factors. So diabetes, high blood pressure, high cholesterol, unfortunately getting older.
There's
positive-
genetics too.
Absolutely. So a family history.
Yeah.
So patients who have a family history of heart disease are at much higher risk. Cigarette smoking. These are all very potent risk factors for the development of blockages in the arteries, and then risk factors for one of these blockages cracking or rupturing and a blood clot forming on top of it.
What about alcohol use or abuse, I should say?
Yeah, alcohol use is associated with heart disease as well. The risk of heart attack is higher. It's not one of the classical ones that I mentioned previously, but the risk certainly does go up.
Dr. Ali, I want to throw a spoke in your tire. We just came out of a pandemic, and you know, COVID was a big deal for everybody. But we did see more heart attacks and cardiac emergencies after patients got vaccines.
We did. Yes, we did. I will agree with you. What we saw a spike in thrombotic events. So blood clots in the lungs, blood clots in the heart arteries causing heart attacks. And we saw it in the patients who had been recently vaccinated. So within a week or two after vaccination, and they developed heart attack or they developed pulmonary embolism, blood clot in the lung, etc. We've not seen that recently because, of course, now we're not routinely vaccinating for COVID anymore. But yes, we did see that. It is true, but I think it's less of an issue now.
Yeah, we need more long-term data from, you know, probably from international basis to see if there's any correlation between those vaccines and people showing up with heart attacks now.
Yeah, I think it's unlikely that what we're seeing now is traditional risk factor associated heart attacks.
Right.
We did see a spike in those COVID vaccine heart attacks and events like that, but I think for the most part, that's finished.
Yeah.
Okay. Well, stay tuned because we have more coming up after this break. Don't go anywhere. Come back and join us very soon.
Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates' gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, number one healthcare for the entire family.
All right, welcome back to Medical Associates Health Check. So we were just getting over the signs and symptoms, but we want to get into how we actually manage a heart attack. Like we just said, this is a life or death, literally emergency. So
Absolutely.
Dr. Ali, what do you recommend for these kind of cases?
Well, the first and most important thing to get across to the viewers is not to stay at home minding your chest pain. All right, we always recommend patients who are having chest pain, heaviness, tightness, discomfort in the chest, get into the emergency room, get checked. The reason is We need to run an ECG as soon as possible. Ideally, within 5 minutes of that person getting into the emergency room, they should have an ECG done. The ECG is going to tell us whether there's a particular pattern that is diagnostic of a heart attack or highly suggestive of a heart attack. And if it is, it's a true medical emergency. Heart attack means that blood vessel is totally blocked and heart muscle is dying. And every minute that goes by, more heart muscle is dying and the patient is at higher risk of death.
Right. So sometimes, the ECGs look like gibberish to plenty of people. In the hands of a skilled person, they'll obviously be able to recognize what is wrong. In terms of blood tests and utility in blood testing for patients who are having a heart attack.
We routinely send off blood tests, blood count, kidney function, and what we call cardiac enzymes. And those blood tests are released into the bloodstream when there is heart muscle damage. The problem with the blood tests is there's a significant delay before those blood tests start to elevate. So you're sometimes talking 6 to 8 hours before those blood tests start to elevate after somebody has already started having a heart attack. And as we just mentioned, time is muscle, heart muscle. So we don't wait for the results of those blood tests before we act. That's why that initial ECG is so important.
You know, we have like global standards for acting on these kinds of things, right? We would read and it said door to balloon meaning like a stent or putting in a stent into a vessel, and we have a time frame for that. What's the time frame for that, doctor?
Well, I'm glad you mentioned. So ideally you want to have that door to balloon time less than 90 minutes. We've been able to accomplish that most of the time in 30 to 60 minutes.
Right.
Where I trained in the States, it was routinely 20 to 30 minutes. So we're not that far from major international centers. And we're definitely well below the cutoff, so to speak.
Right. Okay.
And often when they present in the emergency room, we see that ECG and one call, Dr. Ali, you need to come out now.
Fortunately or unfortunately, yes. So once we see that pattern on the ECG, it means that everything gets set into motion immediately. The cardiac catheterization lab team is called out. Everybody's within the hospital within about 15 minutes. We get in there, we do an emergency procedure called a coronary angiogram. We take pictures of the heart arteries and see what is totally blocked off or partially blocked off. And then most of the time we open it up with an angioplasty and a stent procedure. And basically what that entails is I wiggle a little wire down the artery beyond the blockage, and then using a combination of balloons and stents, which are little metal scaffolds, we restore the blood flow in the artery.
So a common question our patients ask is the procedure painful? Because we start to tell them, we thread a catheter through the wrist, and they're like, Doc, no, that sounds painful. I don't want that.
Yeah, so we give a little local anesthetic right at the site where we're doing the procedure. I do 99.8% of my procedures from the wrist. We only use the leg these days if it's technically impossible to complete the procedure from the wrist. Beyond the local anesthetic, the insides of the blood vessels don't have any nerve endings. So while I'm advancing wires and catheters up to the heart and so forth, the patient doesn't feel anything. So generally speaking, the procedure is for the most part painless, with the exception of that initial local anesthetic to put in the tube in the artery and a little medication that we give right after we put the tube into the artery, which stings for about 30 seconds.
Okay. And there's, patients will say, well, I don't really want that procedure. I want to use a medication. Is there a medication available? What would you tell those patients?
Right. So the next best treatment for a heart attack, apart from doing an emergency procedure, angiogram, angioplasty, stenting, is to give a clot-busting medication. Before the advent of angioplasty and stenting, that was the only thing that was available. And the clot-busting medications, if given very, very, very early, are effective. They do come with a number of caveats. Because we're giving the medication through the vein, it goes through the entire body. And it has the potential to break up blood clot all over the entire body, and that comes with it a risk of bleeding. It's also a time-limited option because beyond 12 hours after the onset of the patient's chest pain, that blood clot is so thick and organized that the chances of being able to open it up with a clot-busting medication are close to zero. So really the clot-busting medication is most useful if it's given very, very early, within a couple hours after somebody starts having their symptoms.
So, I mean, in our setting, the gold standard is angioplasty, right? And then second option, if we can't get angioplasty, is to go for thrombolysis.
Thrombolysis, yes. That is the next best treatment option, but it's next best by a long way. The best treatment option, hands down, internationally proven, is angiogram, angioplasty, and stenting.
So, on average, how many angiograms and angioplasties do you think you would have conducted in Trinidad and Tobago?
Too many?
Yeah, more than you should.
Yeah, I don't have the number.
data.
Yeah, I don't have the numbers. But again, fortunately or unfortunately, we do this procedure almost every day.
Yeah.
You know, the burden of coronary artery disease, heart attacks in Trinidad is very, very high.
Yeah.
And this being the best treatment option available, we have to do this procedure almost daily, up to yesterday.
All right. So, Dr. Ali, I mean, we're going to take a little break now, but when we come back, we'll dig a little deeper into the cath lab and what we can do and anything that's new
Advances.
for treating heart attacks.
So don't go anywhere. Stay with us and we'll catch you after the break.
Do you need a coronary angiogram, angioplasty, or stent? At Medical Associates Hospital, we have the most experienced team of general and interventional cardiologists who provide quality care to our patients. Schedule your appointment today, 750-2278. Medical Associates Hospital, #1 healthcare for the entire family. Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, #1 healthcare for the entire family.
So welcome back, guys. We're getting into the treatment options, and we were speaking about the cath lab in particular. So Dr. Ali, what are the special things that we do in the cath lab really to manage these patients?
Well, the most important thing is to get that artery open. Once we've restored blood flow, heart attack is over.
Right.
All right. And that's why it's called door to balloon time.
Right.
Once we've introduced the device into the heart artery and restored the blood flow, heart attack is over. And then we can take our time and plan what we have to do after that.
Yeah.
Sometimes we encounter situations where there is a massive amount of blood clot inside the artery. And that blood clot, probably because patients have presented a little bit later than they should have, the clot has started to organize. And one of the things that we can do is we have special devices that we can actually remove blood clot from the artery with a catheter called mechanical thrombectomy. And that will also help us to then be able to more easily deliver our balloons and stents and that type of thing to help prevent the artery from collapsing back down on itself.
Yeah. So, no patient is the same, and even doing these procedures are highly risky, very technical, very difficult in some cases. Not everybody's the same. I mean, anecdotally, when I'm with you, Dr. Ali, in the cath lab, we have a little running joke, right? Yeah, we have a little running joke. Once I am there, we need every single possible emergency operational activity there in case of something happening. For example, might have been doing a procedure and then that patient just suddenly arrests on the table. So we have to stop doing the procedure now and revive a patient. Yeah. So, there are other things that go along with treating a heart attack, not just doing the angioplasty. but we might need to put in a device, or you might do something special for these patients. What else can you do, in managing those kinds of difficult cases?
Yeah, so some patients, as you say, very complicated procedures, and they require additional support. Their blood pressures are low, or they're in heart failure, and sometimes we need to put patients on a breathing machine in order to do the procedure, because the patient has to be able to lie flat, and if they're in heart failure, they may not be able to tolerate the procedure. Sometimes we can use a special device called an intra-aortic balloon pump, which is a special support device that's inserted from the artery in the leg and then attached to a pump, which essentially takes the workload off the heart. And that then gives us a little bit more time to work on the artery, restore the blood flow, and stabilize the patient while we can do that.
Yeah.
So you have, the heart attack, you have the procedure, you manage the complications. What happens to the patient after the procedure?
So typically, before the advent of angioplasty and stenting, patients would be in hospital for 7 to 10 days with a heart attack. Now, with our advanced procedures and restoring blood flow much earlier, we'd limit the amount of heart muscle damage. So a patient who presents early gets an early intervention, blood flow is restored, has minimal heart muscle damage, could be home in 48 hours. The aftercare is largely dependent on what happened with the patient and what happened with the overall pumping strength of the heart. There's always some degree of heart muscle damage with a heart attack. We want to minimize that by doing the procedures early and quickly, but there is always some. So really the aftercare and how long somebody would spend in the hospital is going to depend on how much heart muscle damage there was.
Do I think the other thing is a lot of people think they will get the procedure, everything is fine, and they don't always put enough emphasis on follow-up after you go home. How often or how soon do you see your patients in clinic after they go home?
It depends a little bit on their hospital course and how complicated or uncomplicated it was. But I will usually see most of them back within a week or two. But you raised a very good point about after the procedure and patients thinking that they're cured. All right, this is a lifelong disease. Ischemic heart disease, the process of the laying down of those cholesterol blockages in the heart arteries never goes away. So patients need to be treated with medications lifelong.
Okay.
The good thing is the medications that we have now are so good that it can prevent the majority of patients from ever coming back with another event.
Well, that's good.
But I could tell you what I see all the time. Patients who follow up, take their medications, come to the office, they do fine. It's the patient who disappears for 2 years and then shows back up all of a sudden. It's an immediate red flag for me. I'm like, Or
they show up with a new heart attack.
We're in trouble here. Or
Generally,
they show up with
yeah.
a new event. Yeah.
Okay.
So the follow-up is critical. And compliance and taking the medications is crucial.
Could you touch on some of the medications that you do use to look at the preventative aspect?
Right. So after a heart attack, after we've put in a stent, patients will need to be on blood thinners or antiplatelet drugs. All right. Some of the most commonly used ones, aspirin, clopidogrel, ticagrelor, and those are ones. Aspirin is usually lifelong. The others are usually for a year after the procedure, but that varies a little bit from patient to patient. We definitely use statin drugs, mostly rosuvastatin and atorvastatin, which are the more potent statin drugs, and those help to stabilize blockages in the arteries, help to prevent further heart attacks. We use medications to take the workload off the heart and help the heart to heal. So medications like valsartan, sacubitril, which is a relatively new one on the market, which is very good at helping the heart to heal and improving the overall pumping strength of the heart. So it's usually a medication cocktail, and that's part of the problem, because a patient may come into the hospital never having taken a medication in their life, and they get discharged with a prescription for 5 or 6 different medications, and they are hesitant and they're concerned, and everybody's concerned about medication side effects.
Correct.
My advice to them is always listen. I understand, but talk to me first before you do something that could be potentially dangerous.
Yeah.
So if you think you're having an adverse reaction to a medication, call me. We'll talk about it. We'll talk through it. It may be a real adverse reaction. It might not be. And we can make a shared decision about adjusting medications or what needs to be done to keep that patient safe.
A big part of it is really modification of lifestyle, in managing a patient holistically, I mean, Dr. Ali, I wanted to train one other thing. We treat those patients with, they have some new drugs for diabetes that actually work really well for heart patients who have like heart failure as a result of their heart attack. Those new drugs, you mind mentioning a few of them?
Yeah, so I assume you're talking about the SGLT2
Yeah, correct,
inhibitors. Yeah, so empagliflozin, dapagliflozin, those are the two ones that have indications for heart failure as well as for the treatment of diabetes. Again, phenomenal new drugs that have transformed almost the treatment of diabetes and heart failure. So the medication regime now is really good. It's really good. And unfortunately, in our setting, in our environment, our patients are very scared of taking medications. And there's no way around it, unfortunately, so that we have to discuss with them and counsel them and talk to them about why the medications are important. And most of the time, if you take that extra 10 minutes to discuss with the patient, okay, this medication is important because of this, this medication is important because of this, they will comply. Yeah, they'll do it.
So off the bat of that, what would you suggest as preventative measures against heart disease and heart attacks?
The best prevention is to get yourself checked for risk factors. So get screened for diabetes, check your blood pressure, get your cholesterol checked. Of course, if you smoke cigarettes, stop smoking. You can't do anything about your family history. You can't do anything about getting older. So what we want to look at is what we call the modifiable risk factors. And if you are diabetic, make sure your diabetes is well controlled. Your hemoglobin A1C is under 7. If you are hypertensive, make sure you're taking your blood pressure medications. Make sure your blood pressures are well controlled.
So
Exercise.
I was going to say exercise. Last month we spoke to Dr. Pandey and he was saying the same thing, exercise, get those 10,000 steps in a day.
Absolutely.
Yeah. Dr. Ali, I will see a patient that comes in the emergency room. They tell me they have chest pain, but before they come to the emergency room, they like a garlic tea. They like to chew on the garlic. They like some form of alternative medicine. I don't know if it's because it's a common practice in Trinidad and Tobago. Is it something they're encouraged to do? But what's your viewpoint on it?
We have to look at what's causing the heart attack. All right. So what causes a heart attack is a blood clot in the heart artery that is completely or partially obstructing blood flow. Unfortunately, no amount of garlic or garlic tea or any
Turmeric
other
tea, anything.
herbal concoction is going to restore that blood flow. So what that patient needs to do, as we've said before, is get to the emergency room. Get to the emergency room, get evaluated, get an ECG, get treatment started quickly. Don't wait to brew the garlic tea.
Don't even bathe. Don't even bathe. We don't really care. Just get there.
Just get there. Although, do you think that these alternative therapies have a role in preventative medicine?
When I see patients in the office and they tell me, well, doc, I want to do X, Y, or Z herbal remedy, my response to them is usually, well, it's probably not going to hurt, but I can't tell you that it's going to do anything to help you.
Yeah.
Because we don't have data to back that up.
Yeah, so Dr. Ali, I want to thank you for your time. Yes, compliance is important in terms of managing these patients afterwards. And, I want to go back to the point of if you're having chest pain, just don't play it off, get it checked out, see a doctor. It's an emergency, essentially, So Dr. Ali, thanks for taking your time today.
Thank you.
You're very welcome.
Yeah, and thank you all for tuning in to the Medical Associates Health Check. Take care.